I'm Dr. Anthony Valeri. I'm the Medical Director of Hemodialysis at Columbia University Medical Center in New York City, and I was asked to discuss the pros and cons of early initiation of hemodialysis in patients requiring renal replacement therapy. I think the impetus for this really goes back many years to where it had been noted that survival on dialysis outside the United States, in Europe, in Japan, was better than within the United States. And it was also noted that patients outside the United States tended to start dialysis at higher levels of residual renal function. And the question became whether earlier initiation provided benefits to those patients. There was a series of small retrospective observational studies that were done in the late 70s, 80s, up to the mid-90s, some of which suggested a benefit. The most recent of those studies was published in the mid-1990s, 1995, in the American Journal of Nephrology by Tattersall and his group, and they looked at 63 consecutive patients beginning renal replacement therapy. 6 of those patients unfortunately died during the follow-up period that averaged about 10 months. They found that those 6 patients, compared to the remainder of the population, tended to be older, tended to have more comorbid medical conditions, but also tended to start dialysis at a lower mean daily residual KT over V. So small studies like that, again, all observational, seem to suggest that maybe earlier initiation of dialysis would produce better outcomes. And that has led to a trend in the United States over the past decade and a half, where in fact patients have been starting dialysis at higher levels of residual renal function. So taking data, for example, from the USRDS, they noted that in 1996, about 19% of the patients beginning renal replacement therapy began at an eGFR of greater than 10. Over the subsequent decade, that has risen from 19% to now 45% for data from 2005. More than double the number of patients now starting at higher levels of residual renal function. The mortality and survival has actually improved over this past decade and a half. So for example, again, data from the USRDS showed that from comparing data from 1995 to 2010, that the adjusted mortality, adjusting for age, gender, race, and comorbid medical conditions, has actually gone down 28.4% from 377 to 267 deaths per 1,000 patient years. And with that, the overall survival has actually improved. Now clearly, many other things took place in the last 2 decades that could account for this improved survival. The Fistula First initiative, the use of the standardization of the minimum dose of dialysis that patients should receive, and maybe the onset of early CKD or pre-ESRD care. So what kind of data do you really want to see that beginning dialysis earlier is of benefit to the patients? Well, really, as physicians, we want to see the highest level of evidence being from prospective randomized controlled trials. And to that end, there's really only one study that has been published that meets that criteria. And that is the Australia-New Zealand IDEAL trial that was published in the New England Journal back in the summer of 2010. What actually turned out is that in the early group, the starting eGFR at time of initiation of dialysis was about 12, so they achieved their goal, although almost 20% of the patients were not able to start dialysis until their eGFR was under 10. More importantly, in the late group, where the target eGFR for starting renal replacement therapy was set at 5 to 7, the average eGFR when they actually began dialysis was 9.8. And in fact, more than 3/4 of the patients actually had an eGFR greater than 7. So clearly, one caveat in the study is that there is significant overlap. And many of the patients assigned to the late group actually had to begin dialysis at slightly better, higher levels of GFR because of symptomatic uremia or problems with fluid and electrolyte control that could not be controlled without dialysis treatment. What did the trial show? Looking at hard endpoints in terms of mortality, risk of hospitalization, there was no difference between early and late initiation. And in fact, the group starting dialysis late, on average, began 6 months later. So that's not an insignificant difference, both in terms of quality of life, having to start dialysis, and medical costs in terms of providing dialysis during that time period. One reason we often initiate dialysis when patients don't seem to have significant symptoms is because of our perception that the patient is showing signs of malnutrition. They did do a subset analysis in the IDEAL trial looking at those patients who had significantly depressed serum albumins less than 3.5, where we know that there's an increased mortality risk associated with that. There too, I must say, the IDEAL trial did not find a difference between the two between early versus late initiation in patients with low serum albumins. But here, it's a small subset of the total study population, and so that may be something that could be considered in future trials, looking at earlier initiation of dialysis in patients who may have markers of malnutrition or known markers of poor outcome, to see whether earlier initiation in that specific subpopulation might be of benefit. But until that type of data is available, we're really left with the results of the IDEAL trial. And then just to quote from the author's discussion themselves, I quote, "Results show that with careful clinical management of chronic kidney disease, dialysis can be delayed for some patients until the GFR drops below 7 cc's per minute, or until more traditional clinical indicators for the initiation of dialysis are present." I think what that suggests is that early initiation of dialysis may not be what's of greatest benefit to the patient, but early introduction to CKD care may be what really results in better long-term outcome.